So we're going to talk about managing your medicines. Basically, the two goals of this presentation. We have about 35 minutes for you to have to listen to me, and then I get about 15 minutes for questions. So I'm going to move fairly quickly, but we'd like to cover basically how do the antiretroviral medicines work to fight HIV, and how can you manage side effects. Antiretrovirals work because they interfere with the virus's ability to use cellular material to reproduce or replicate itself. And without that, the virus can't reproduce itself, so it gets far less in terms of its concentration in plasma, seminal fluid, cerebrospinal fluid, lymph nodes, etc. Because of this, the immune system begins to improve with a decrease in viral load. Obviously, there's an increase in the CD4 count. The goal, of course, gold standard for antiretroviral therapy is an undetectable viral load less than the lowest level of quantification, which for most folks in the metro area is 50. Kaiser is still using a 75 copies per mil as their lowest level of quantification. Antiretrovirals target very specific steps in viral replication. Currently, we have medications that are available that block 4 different steps in the process of viral replication. So basically, we have entry inhibitors. Currently, the only FDA-approved one is Fusion or T20 or Infrufertide. All of the medications have at least 3 names: their proprietary name, which is their trade name, their generic name, and then the nickname they get in development. So I'm going to try to use all 3 today, although I'm moving more towards using trade names or proprietary names, particularly with combination drugs, because it's very difficult unless you use the trade name. So those work by blocking the virus's ability to even enter the. Then your nucleosides and your non-nucleosides both work at the same place in the viral replication process, which is before when the RNA, when the virus is trying to transcribe into the DNA and get into the cell nucleus. And then the protease inhibitors work after the virus has used up the material it needs in the cell nucleus and is getting ready to bud out of the cell. There's also a novel agent, the integrase inhibitors, which Mike will refer to as well, that work at that. Actually, they work in the nucleus, don't they? Yeah. So actually work before that step. So why do we want to treat HIV? We want to treat it because people who take antiretrovirals when it's appropriate have much fewer problems, what we call morbidity and mortality. Fewer people die. They have fewer illnesses, fewer hospitalizations, fewer complications. Generally, quality of life is greatly improved. We restore and preserve the function of the immune system, and we can provide now maximal and durable suppression of viral load if you take your medicines. This is just a graphic representation of what happens when you start taking antiretroviral medications. Soon and very soon, somewhere between 4 and 26 weeks after starting antiretrovirals, the viral load should be undetectable at less than the lowest level of quantification, which on this slide is 50. This is the laundry list of nucleoside reverse transcriptase inhibitors, or what we sometimes are referred to as NRTIs or nukes. And this is just the list in alphabetical order. Xiagen, Videx, Amtriva, Epivir, Zerit, Viriat, Hyvid, Retrovir, and on either side of that you can see the generic names and the proprietary names. And the nicknames, I mean. We now have a variety of combination tablets. Combivir has been around for a while. That's the combination of AZT and 3-TZ, or zidovudine and lamivudine. Retrovir and Epivir. Epsicom is the combination of lamivudine and abacavir, which is Epivir and Xiagen. Trizavir is a 3-nucleoside drug, has AZT, Xiagen, and Epivir. Truvada is tenofovir and emtricitabine, or Viriad and FTC, or Amtriva. And Atripla is the newest combination drug recently approved in the last month or so, which combines 2 nucleosides and 1 non-nucleoside, tenofovir, emtricitabine, and efavirenz, which is Sestiva. This slide just shows again that NRTIs work using your genetic code. They take pieces of the DNA that the virus would normally need by blocking the enzyme we call reverse transcriptase. And without that being present, the virus cannot transcribe itself and move on through its replicative process. There are only 3 non-nucleosides currently FDA approved. There is one coming down the pike, which Mike will probably talk about again, TMC 125, I believe it is. And these work in exactly the same location in the cell as the nucleosides, but they have a little different side effect profile, potency, durability, etc. Protease inhibitors is the 3rd class of drugs that have been around for a while. Again, this is a listing just in alphabetical order. Reataz, Prezista is our newest one. That's darunavir. Was recently was on expanded access and then very recently FDA approved. Again, has a novel resistance pattern. That's why it's so important to us for people who have multi-drug resistance, particularly multiple PI mutations. Like Lexiva, Crixavan, we don't use much anymore. Kaletra, Viracept, I've never used, hardly at all. Norvir, which is used now mostly as boosting, and we'll talk about boosting in a minute. Inverase and Aptivus, which is timpranavir, is also one of the new or novel PIs that has recently had FDA approval within the last year. Again, has a different set of protease inhibitor mutations, so people with pre-existing multi-drug resistant virus or have acquired that can use that and hopefully get good viral suppression. Entry inhibitors, again, the only FDA approved one we have is Infufratide or T20 or Fusion. Many of you are familiar with this. This is an injectable that's given twice a day. And then the other entry inhibitor is the CCR5, which is still in phase 3 trials. These agents work where the virus attempts to enter the cell. And Fusion basically kind of coats the cell so that the virus can't enter, and the CCR5 actually binds to the binding site that the virus would normally bind to so it can't get in. So they actually work a little bit differently. Antiretroviral therapy requires 3 fully active medications to be effective, usually from 2 different classes. And it's been clearly demonstrated that this is what's necessary to achieve durable viral suppression. It has been found that, of course, ritonavir, because of its inhibition of specific enzymes in the liver, is a powerful potentiator, particularly of other protease inhibitors. So most protease inhibitors are given boosted because the durability of the regimens and the number of people who achieve undetectable viral load are far greater when they take a boosted PI as opposed to an unboosted. This slide I couldn't really correct. The word dual is a little bit of a misrepresentation. What this is really talking about is boosted PI as opposed to dual PIs. There are some folks who are actually taking full strength 2 different protease inhibitors, sort of a avant-garde approach, which I use occasionally when they absolutely cannot tolerate Norvir or ritonavir. But basically this gives you the pharmacokinetics of how much better and how much steadier blood levels are with boosted PIs as opposed to a single protease inhibitor by itself. This slide, which is extremely busy, the reason I put this in here, or actually Debbie and I put this in here, is just to illustrate a couple of things. The multicolored bands that go down just show you if you have a boosted, the bottom line is the boosted protease inhibitor with 2 nukes. And then as you go up, you have non-nucleoside with 2 nukes, triple nukes. I'm not sure what the PI triple, what that means. But anyway, as you go down there, that shows you the percentage of people who have become undetectable less than 50 at 48 weeks. And this was a meta-analysis of about 13,000 patients. So the data is pretty overwhelming that boosted PIs are certainly very effective. Also, with boosted PIs, the CD4 increase, the little rectangular box there on your right, shows that people under 50 copies on a boosted PI regimen had approximately 209 additional T cells, non-nukes 174, nukes 150, and PI unboosted only 178. So not only is the CD4 response better, but the viral load suppression is better. When you are looking at an antiretroviral regimen with your clinician, of course you're looking at a lot of different things, underlying conditions such as pregnancy, hepatitis C, hepatitis B, cardiovascular disease, various drug-drug interactions, maybe you have seizure disorder, you're on analeptic drugs, various lifestyle conditions, and toxicities, both short and long term. There have been a lot of improvements. Hopefully most of you have experienced this. Fewer pills, combination pills, and once daily dosing. I think once daily dosing is one of the biggest improvements. This is data that from patients about what their preferences were, whether pill burden was more important or whether once a day dosing, and obviously 68% of the respondents said they just as soon take 4 or more pills once a day than to have to take pills twice a day. This is an old-fashioned regimen that just shows the difference between then and now, where someone would have to take 2 AZT capsules, an Epivir capsule, and 4 Indinavir capsules 3 times a day, very religiously, 8, 4, and midnight in order for them to work. So regimens have been extremely simplified. These are examples of common regimens that people who are antiretroviral naive, who've never taken antiretrovirals, might begin with. For example, a boosted protease inhibitor such as atazanavir, 2 atazanavir capsules with 1 ritonavir capsule and a single efavirenz tablet, or you could combine that with Viriad, which is tenofovir, or you could do epsicom efavirenz or Truvada efavirenz, which are common combinations as well. So efavirenz, and now a tripla, of course, is just a single tablet, which combines the Sestiva, which is efavirenz, the tenofovir, Viriad, and emtricitabine, which is Emtriva. So it is possible for someone who is antiretroviral naive, particularly, who gets therapy started at a reasonable time, could be taking 1 pill once a day. Okay, adherence. I see some familiar faces out there, so this isn't anything new to those of you whom I know. But if you don't take your pills, they don't work. If you take your pills, they work. These are very potent medicines. They work if you take them. You have to take the correct dose. You have to take them at the right time. Some of the medications have meal considerations, some do not. I really work at trying to prescribe regimens that do not have food restriction, because it just makes life a lot easier. If you can take them, if you have a full tummy, you can take them if you have an empty tummy. It doesn't matter. Storage is a huge issue, and again, I try to avoid medications that have very fussy storage requirements. But sometimes you can't avoid it. So adherence and response, this graph just shows you that the more adherence you have, even with greater than 95% adherence, in this particular data set, only 81% of the participants reached an undetectable level of less than 50 copies per mil. So, and as you can see, as you go down the adherence ladder, fewer and fewer and fewer people are achieving undetectable viral loads. Again, this slide is really to emphasize that over time, adherence becomes even more important. You can see in the early months, it doesn't especially in the first month, it makes no difference whether you're taking your pills or not correctly. Anyway, everybody gets a little bang for their buck. But as the months go by, the further your adherence drops, you can see that the 100% people, again, in this particular data set, achieved a little greater than 60, around 65% at 12 months. 80 to 99% folks were just barely coming up to 50% viral suppression, and anything less than 80% had a less than 20% chance of having an undetectable viral load. Same drill, but related to disease progression. People who take their medications achieve good viral loads, and immune reconstitution have very, very low incidence of HIV-related complications. So viral suppression is determined by adherence, how well you take the pills. Durability is directly related. In other words, how long your regimen is going to work for you. It is a variable that is totally in the patient's control. We, as the clinical pharmacist, as the clinician, as the nurse, as the social worker, as the mental health therapist, can all provide support and encouragement and tools, but certainly it is within the patient's control. Again, this just demonstrates when the virus goes down, and then if a person has, when they are starting to have poor adherence or missing medications or not taking their medications, viral rebound occurs readily. Resistance develops for a variety of reasons. One is the virus replicates itself very rapidly, tens of thousands of times every day. And it's a very stupid virus in that way. It makes multiple mistakes every time it replicates itself. So it creates all kinds of mutants. So again, one of the major goals of viral suppression is avoiding viral replication. If there is no virus to reproduce itself and replicate itself, then no mutations can be formed and no resistance can develop. One of the problems with some of the newer regimens, particularly like Atripla or before using Truvada, Favirenz, is, and I always caution patients about this, is two of the drugs in Atripla have a very low genetic barrier to the development of resistance. They are single mutation drugs. K103 knocks out your Favirenz, 181 knocks out your FTC. So you've only got one drug in there that requires 4 or 5 mutations, the Truvada, tenofovir, before it's gone. So regimens like that require the strictest of adherence, because you must take the pill every 24 hours, plus or minus 2 hours, or you're going to possibly ping off one of those mutations, and then elements in the regimen are gone. Reasons why people miss dosages. These are self-reports of patients: forgot, sleeping, gone away from home, changing routine, too busy, did not feel well. So you can see there's a variety of reasons spread out across the board, nothing terribly predominant. This slide just is to emphasize the difference between clinicians' perception of why patients don't take their pills and the pill taker's perception. Clinicians predominantly say pill burden is the main reason why people don't take their pills, or side effects. Patients, however, don't rank those very high. They look at more things like complexity of the schedule, again, food interactions, food restrictions, and a lot of others. One that's commonly mentioned is disclosure, privacy. It's difficult to take your medicines if you're living in a communal household, if you're still living with your La Familia, and you have to take your medicines home and keep them in the medicine cabinet or in the kitchen or whatever. People are going to wonder what those medicines are for and why you're taking them. Clinicians and patients come at antiretroviral therapy from 2 different perspectives. As a clinician, I'm looking at how this is going to affect your health, how this is going to make you feel better, improve your quality of life, include your duration of life, etc. Patients are coming at it in terms of how will this affect my life. And so we have a gap to bridge there, and that's an important thing to do in developing a partnership with your prescriber. Joint decisions need to be made. Individual schedules need to be taken into consideration. All other medical conditions have to be taken into consideration. We have to look at the full medication profile, all drug-drug interactions, etc. Things to do: talk to your healthcare team and peers. I always try to give lots of visuals to people so people have an idea of what the pill looks like. In our office, we actually have a pill book, which is great. It's a big 3-ring binder that actually has the actual pill in the side with a little slip of paper next to it that talks about it and what it means and what it does, so people can actually look at it and feel it and identify it for what it looks like. We really encourage people to personalize their treatment plan, pick the time of day they're going to take their medicines, with or without food, what time works best for them in terms of what they're doing in their life. And the other thing to do is, especially if you are just beginning medications, is to have a plan in place prior to starting your medications for side effect management. So there's something available to treat diarrhea, to treat nausea, muscle aches, joint pains, whatever might come. And cues are always helpful. Reminder watches, buddy calls, anything that might work for somebody is great. Medication calendars, some people do really well with, star charts or using a medication administration record, much like nurses would use in a care facility. Pill boxes, the cassettes are helpful, 7 days at a time. Setting up the pills a week at a time, establishing set times, alarms, etc. Biggest difficulty, I think, is planning for alterations in life. Things happen. You have to go visit somebody, you go to a family reunion, you travel, you get sick. So contingencies for how am I going to take my medicines when those things come up, having those thought through helps to avoid missed dosages. Refills are a real problem as well, especially if you're on multiple medications, not only HIV medicines, but maybe lipid-lowering agents or cardiac drugs or diabetic medications or antihypertensives. And that's getting all of your medications on the same fill date. And if you can't do this alone with your pharmacist, then sometimes it's nice to get an advocate, a nurse or your provider or somebody to help you with that, because it makes it a hell of a lot easier if you only have to go once a month or go to your mail order every 3 months or whatever, than to have to, if you're on 4 or 5 or 6 different medications and you have to trek back and forth to the pharmacy every week or twice a week or whatever, it's just crazy making. You're spending your whole life going to and from the pharmacy. So that's a good thing to work towards. It's not easily achievable goal, but it has to be a partnership between the provider and the patient and the pharmacy. Adherence has a lot to do with faith and belief systems. As a patient, you have to believe that the medicines are going to help you, that they're going to make you feel better, that in the long run it is worth your time and effort to take them. The other thing to acknowledge is that everybody misses dosages at some time. And it's very important to be honest with yourself and also honest with your clinician, and not just say to the clinician what you think they want to hear, because that doesn't help you and it doesn't help them. And everybody's going to miss dosages. Everybody. Side effects, they're much more common when regimens are initiated. The induction phase can be very difficult, especially the first couple of weeks. Usually most transient or self-limited side effects are going to go away within the first 2 to 6 weeks. If they don't, then probably there's something in that regimen that's not compatible with you and not going to work out, and we need to look at a different regimen. Most side effects can be managed. Antiemetics, anti-nausea pills, antidiarrheal pills, pain medicine for aches and pains, etc. There are certainly significant side effects from all 3 classes of medications that we use most commonly: muscle aches and pains, peripheral neuropathy, which is numbness, tingling, pains, and aches, usually in your toes, feet, and shins, forelegs, liver infiltration with fat, inflammation of your pancreas, loss of your bone marrow's ability to make red cells, white cells, or clotting cells, and a very serious complication we call lactic acidosis. Fortunately, that's extremely rare, although much more common in women and much more common in pregnant women who have HIV disease and are being treated. It has to be watched for very carefully. And that's a complex of symptoms that are listed below there. Just briefly on abacavir HSR, Xiagen or abacavir is the only drug in our group that has this odd sort of allergy or hypersensitivity reaction that consists of almost like a flu-like syndrome, almost always characterized by fever, sometimes by rash, cough, sometimes gut distress, nausea, vomiting, diarrhea, generalized aches and pains, etc. Almost always occurs on day 11, somewhere between day 10 and 14. It increases after the dose and goes away slowly as the drug level goes back to trough, and then it returns when you take the next dose. The HSR, the hypersensitivity reaction in and of itself, is not dangerous. It's uncomfortable but not dangerous. And it can be treated generally with diphenhydramine, which is Benadryl, and acetaminophen, which is Tylenol, quite successfully. But again, you have to have accessibility to your clinician, ability to talk this out and get appropriate treatment. And if you cannot be treated through the HSR, if we're unsuccessful, then obviously that's when Xiagen or abacavir becomes basically on your no-no list, and you can never take it again because repeat exposure to Xiagen at a later date can result in hypotensive shock and death. All of the non-nucleosides, their biggest problem is rash, and nevirapine and efavirenz, Aviramune and Sestiva about the same. We don't use much dolaverdine or Rescriptor anymore. CNS side effects are well known to any of you who have taken Sestiva, particularly in the early days, the vivid dreams, cognitive impairment, hangovers in the morning, worsening depressive reactions, etc. Most people that goes away. If the rash occurs, again, we can manage most of the rashes to non-nukes. Again, we can treat with high-potency antihistamines such as Vistaril, hydroxyzine, famotidine, even put you on prednisone if we need to. Again, some people we can't treat through non-nuke rashes, but most people we should. This is just an example of a classic morbilliform rash. Kind of looks like measles, itches like hell. Sometimes you'll have fever with it as well. It's quite miserable. It's very discouraging, I know, to patients when they really want to take their regimen, they're just getting started, and then, you know, day 10, 11, 12, 14, they come in, you know, covered in these itchy red bumps, and they're pretty upset. One thing I always try to do is forewarn people about what can happen in those first few weeks, including immune reconstitution inflammatory syndrome, particularly more common in people who start at very low CD4s and high viral loads, can actually be quite a bit sicker during the first 12 to 18 weeks than they were before they started medicine. So if patients don't know this up front and then they get hit with something bad, again, it goes back to that thing where it sort of decreases the faith in the provider. It's like, whoa, dude, you know, you said I would be better, and now look how I'm doing. We're all pretty familiar with the metabolic abnormalities. I'm not going to talk too detailed about this. Diana's giving a talk about that. But we see fat loss in the periphery, the legs, the buttocks, the arms. People develop what we call phlebomegaly, where you can see the veins because the fat shrinks away from the veins and they begin to pop out and stand up. We see facial fat loss, especially the facial cheeks, and then the adiposity in the stomach, the truncal obesity, which is actually visceral fat, so it's infiltration of fat in and around your organs, not like subcutaneous fat like the typical middle-aged man beer belly, and then the dorsocervical fat pad, which is the buffalo hump on the neck. Lipid abnormalities, high triglycerides, high cholesterol, low, high-density lipids, high, low-density lipids, again, all complications of HIV antiretroviral therapy, also complications of living with HIV disease and AIDS over time. Again, we do not know exactly why. Diabetes can be a problem, disorders in glucose metabolism, osteoporosis, osteopenia can be a problem, which is demineralization of bone. That one, unfortunately, is very rare, but it does occur. I have a patient who is very osteopenic and has spontaneous fractures on a regular basis. So we don't know, is this all one single syndrome, is it multiple syndromes, and what are all the things that are contributing to it? Those are some of the challenges we still face. So certainly family history can contribute to it. Certain antiretrovirals contribute to adverse effects more than others, and certainly certain factors related to a person's HIV alone. I think we talked mostly about those kinds of things. So metabolic disorders, what can you do? Stop smoking, that's number one. Start exercising, eat a low-fat, high-fiber diet, move around, be physical. And then if none of that works, then we still have to add in lipid-lowering agents for triglycerides and cholesterol, so additional drugs such as statin drugs or Lopid, Gemfibrozil, fibrates, etc. Fish oil caps et al. Peripheral neuropathy, we don't see it so much anymore in younger, newer patients because we don't use so much of the agents. The D drugs, particularly Zidovudine, Zerit, which is, what was Zerit? D4T, Stavudine, yeah, couldn't even think of it. And somewhat the old formulations of Videx, DDI, were much more likely to cause peripheral neuropathy. Nowadays, if someone develops peripheral neuropathy, it's probably more related to their HIV. There is some chance of getting peripheral neuropathy with some of our other drugs, but not so much anymore. But the main thing to do is if you're on a drug known to cause peripheral neuropathy is to discuss with the clinician, can we switch to something else? It may not be possible. Maybe you've burnt all your options out and you have to take a drug that causes peripheral neuropathy. Certainly, complementary medicine, data is not overwhelmingly impressive, but there is certainly some suggestion that acupuncture, high-dose vitamin B6, B12 repletion, now there's the lidocaine patches, etc. These are all things that could be done, particularly for severe peripheral neuropathy. Okay, that's it for my slides, and I just have a list here of things that are still in the hopper in terms of challenges for those of us providing HIV care and challenges to the many, many scientists around the world who are doing research around the management of HIV.
Thank you, Jim.
Oh, you're welcome. My pleasure.